Hi, this is Ellie Fishman. I'm live. This is our latest and greatest YouTube Live, and this is YouTube Live looking at misdiagnosis. So 5 minutes. I got 5 minutes. Just to make it clear, this is the end of the year academically. So we wish everybody who's leaving, our fellows, only the best of luck in the new jobs, and we welcome all of the new people who are starting. So anyway, this week, I'm going to talk about misdiagnosis, and I'm going to talk about pitfalls in the kidney. So let's look at several things. One statement that's often made and has been published a lot is that one of the 25% of patients who get operated on for renal masses under 4 cm, the lesions are benign. Well, why is that? So that's the pitfall. If you have one phase acquisition and you see a lesion is fairly well defined and it measures 80 Hounsfield units and 90 Hounsfield units, you say it's a hypovascular papillary renal cell carcinoma. It's important to remember that if you don't have non-contrast, how do you know that that's just not a high-density renal cyst? So many times what gets operated on is a high-density renal cyst. So if you have a single phase, like from the ER, and there's a 3 cm mass, smooth and it measures 90, you can say, well, this could be a tumor, yes, but it could be a high density renal cyst. The easiest thing to do is get a non-contrast scan. Easiest thing to do. The other thing you could do is, if the patient was still around, would be to repeat the scans through the kidney. Because one of the rules we have is, if a lesion's a tumor, even if it's a hypovascular tumor, it's always going to change 20 or 30 Hounsfield units between the different phases in terms of attenuation. So if a lesion stays the same, so it's 85 on venous phase, and then you bring the patient back 20 minutes later, it's still 85, that means it's simply a high-density renal cyst. We don't want to have people get operated on for no reason. So it's an easy pitfall, but something easy to fix. The second thing is, one of the things that's commonly resected are incidental angiomyelitomas. Now, if you have a lesion, a classic angiomyelitoma that has all fat, that's an easy diagnosis, angiomyelitoma next case. Now, sometimes they get operated on. People will say if they're over 5 cm or they have really prominent vessels, you should operate on them because they have a propensity to bleed. I'm not talking about those. Those are easy, okay? I'm talking about what happens is you have a mass and it's somewhat vascular, but there's a little itsy bit of fat in the lesion. If you see any fat in the lesion, it's an angiomyelitoma until proven otherwise. Now, yes, people have written articles that say there's fat in renal cell carcinomas, but those cases are always the same. It's a big renal cell that's really, really ugly that invades the perirenal or pararenal fat. I'm talking about punctate fat. When you see little bits of fat, it's a myelitoma, AML. We make the same statements with the adrenal gland. Small adrenal myelolipomas have little bits of fat, but often have punctate calcification as well. That makes it easy. Now, I will say the small renal AMLs have punctate fat, but don't have punctate calcification. That's a really good rule. Another good rule in terms of renal masses is to, particularly for hypovascular masses, always consider the possibility of infection. One of the common things resected has been abscesses. If a patient has a fever, yes, tumors can cause fevers, okay? But when you have a smaller renal lesion, it's unlikely to cause fever if it's simply a renal cell carcinoma. Abscesses can cause fevers. Renal abscesses typically can masquerade as some flank pain, really doesn't fit in, complications of IV drug abuse, cardiac disease, atrial fib, and the like. So you want to be really careful looking at those lesions as well. It's another pitfall. The other pitfall is you look at the kidneys and it looks perfect, particularly on cortical medullary phase. It looks perfect. I have this in my talks in nice cases. Sometimes you have an infiltrating renal cell that runs along the course of the kidney. On coronal views, when you got them like this, it's so obvious. But if you look at the axials, it's not so obvious, and you will often miss it. They're not large tumors, but they're strategically located, and they're so obvious on the on the coronals and not very obvious on the axials. Okay, that's 5 minutes and 5 seconds. And I promise to do 5 minutes. I know it's hard for me to do 5 minutes, but I'm doing 5:11, 5:12. I'm signing off. I'll see you with misdiagnosis next week as well. Have a great day, everybody.